Good afternoon, everyone. I hope that there is a little bit of energy left in the room, despite it being, late into the day. So my name is Mia, and I work as Medical Humanitarian Advisor at the Doctors Without Borders, or MSF, office here in Stockholm. I'm going to try to give you guys today maybe a little bit of a different perspective or a different view on consequences of the COVID pandemic than what we have seen earlier on today. So I'm not going to talk so much about COVID in itself. Let me see, is this? There we go. No? There we go. So what I'd like to walk you through for the coming few minutes is how we have seen an impact on COVID on three other diseases. So let's say secondary impact of the pandemic. We know that since many years, the global fight against what we call these three infectious disease killers, HIV, tuberculosis, and malaria, we've seen worrying signs over the past years that the development and progress against these diseases have come to a halt. The seriousness of the situation today should not come to a surprise to anyone, because we saw this, MSF team saw this already years ago. We issued a report in 2019, already then warning that especially on HIV and TB, that the development had come to a standstill. This year, teams have done a new assessment, looking at, among other things, how the COVID-19 pandemic and the current economic and social crisis that have followed the pandemic, how they have exacerbated the existing problems for these three diseases. So I'd like to take you guys through a little bit on the three different diseases. Short, I don't want to call it a deep dive because it's so short, but a little bit of punctual examples from a couple of different contexts where we work. But first, looking at, in general, how we've seen the impact on COVID on our activities, I'd like to, split them into three categories. How the pandemic has impacted the access to healthcare for the populations where we work. How we have seen, and I'll get into more details on this, how we've seen a change in health-seeking behaviors in some of the populations which we are there to serve. And also, very importantly, how we saw a shift in funding and resources allocated to these diseases. Now, of course, you can't analyze these things without looking at what was the case before. So of course, when looking at decreased access of healthcare, of course you need to include in your analysis what was the access to healthcare or the level of access before. If you look at health-seeking behavior, to what degree did people seek healthcare before the current crisis? And of course, what was the previous resource allocation or funding situation? So that's important just to keep in mind. Starting to look at tuberculosis, people affected by TB were actually particularly hard hit during the pandemic. We have seen death tolls of TB have increased from 2019 to 2020 back to levels of 2017. 2020 saw around 10 million new cases of tuberculosis globally, and 1.1 million of those in children. Giving you one specific example on Guinea-Conakry, where we saw a particularly high impact on especially tuberculosis during the pandemic, where worldwide commitments were to reduce TB incidence in all countries by 20% by 2020 as compared to 2015. Guinea instead saw an increase of 1.3% of their TB incidence. Now, looking at the impact of COVID on TB, we saw in the three tolls, so the movement limitations that stopped people from accessing healthcare for physically not being able to. Transport were not working. In some cases, they had to quarantine, meaning not allowing them to go to the health structures. In some cases, also, health structures shutting down. So care was no longer available for those who needed it for other reasons than COVID. When it comes to TB in specific, is also that the symptoms of TB or pulmonary tuberculosis are quite in certain extents, similar to COVID symptoms. So there was a lot of stigma around people with tuberculosis being seen as COVID carriers, people to be afraid of, people to be avoided. So of course, that also did not help these people who are stigmatized by their diagnosis to begin with to actually seek the health care that they needed. And then an overall fear of going to health facilities, and that's true, you'll see, for all of the 3 diseases that we're talking about today. People avoided seeking health care for the pure fact that they were afraid of this new virus. Now, trying to look at then what reflections have we had around this? We understand why COVID restrictions to a certain extent had to be implemented, but then we're seeing the impact. So when you look about maximizing benefits for a large amount of people versus what impact the disease actually has. If you look at an incidence rate of COVID versus tuberculosis in Guinea, for example, of course, over the past 2 years, the incidence of COVID have been relatively high, albeit not as high as what we've seen in European countries. Looking at mortality rates, however, they're quite similar. So who are we actually maximizing the benefit for? So I think that's something where we have reflected, where do the priorities lie? And I'll return to that in a second. Moving on to HIV and AIDS, where what we saw during the pandemic was that the prevention services were the ones that were hit the hardest. Globally, we saw a decrease in HIV testing, a decrease of 22%. And we know that being aware of one's status when it comes to HIV infection is very important in terms of controlling the spread. So the fact that testing decreases with such a massive number it's quite severe and can have a long-term impact on how we can manage the HIV pandemic. Also seeing other preventative services such as prevention of mother-to-child transmission decreasing of up to 10% on a global level, which means that you have a lot of new infections in children that we've seen over the past 2 years. For HIV, I want to take you to Myanmar, where, of course, we have a lot of different aspects that impact, for example, access to healthcare, such as the military takeover in February 2021, that has, of course, not had a positive impact on functioning healthcare structures. Shortly after the military takeover, there was a second wave of COVID that hit Myanmar, which basically pushed the health system to a near paralysis. And we have seen direct consequences, and our teams have seen direct consequences of this on our HIV cohorts. We're seeing around 10% of our previous patients that have discontinued treatment. Some have passed away, unfortunately, but a lot have absconded from treatment, most likely directly related to the fact that they could not reach a health center due to restrictions and/or due to the lack of existing health structures. Now, as I said, I can't say for sure health structures not functioning. Is that because of lack of support from the current, let's say, regime? Did my microphone stop now? Yes, no, then we're back. Is it because of that or is it because of COVID? Unclear, but we do know for a fact that COVID has had a negative impact on the access of healthcare in Myanmar. Then you can ask yourself, the restriction measures, were they protecting against COVID-19 or were they de facto an obstacle for HIV treatment? And what does that do to the public health situation of an entire country, if you're looking at the long term? Still, Myanmar was a country that had a relatively high COVID incidence, so there was still a certain acceptance for the fact that this is a disease or an infection, a pandemic that we need to protect ourselves from. Not saying what is a right answer or a wrong answer, but it's just a reflection to have. What are we actually protecting people from? Finally, on malaria, where we've seen a very concerning trend over the past few years, with the case incidence who's continuously increasing. 2020 versus 2019, 14 million additional cases of malaria on a global level, of course, majority of those being in sub-Saharan Africa. 69,000 additional deaths. And there was a study made, so a WHO study, that showed that approximately 2/3 of those additional deaths were directly related to disruption of access to diagnostics and treatments related to the COVID-19 pandemic. And that is access to diagnostics and treatment related to transport chains being disrupted, but also of health facilities not working. And what I will go into after this about funding. So my example for malaria is coming from South Sudan, where you had a COVID incidence that was relatively low. The impact seen in the population, the perception of population, was not that COVID-19 was their biggest problem. One of the big problems is malaria, seasonal, but still a big problem. One of the biggest donors for the National Malaria Program decreased their funding with 30%. It was being diverted to other priorities. That directly meant the discontinuation of support to 200 health structures. And then you can look at priorities. I know we've talked a lot about setting priorities, but priorities for whom? Is it a priority for a donor, or is it a priority of the community? In the case of South Sudan, those lines are pretty blurred. In some cases, you can also talk about priorities of governments. We've already had people mentioning, the difference between the wishes of the scientists, the wishes of the politicians, and how that sometimes clashes. In these cases, you also have the aspect of the community and the population. They might not share those priorities, but they have to live with the consequences. So talking specifically a little bit about the funding, because that's something specifically related to TB, HIV, and malaria. We've seen over the past few years that funding is flatlining. Support for non-COVID related humanitarian needs have fallen over the past 2-3 years, and we're seeing dramatic consequences thereof. We have an exacerbation by the pandemic of this already existing donor fatigue and competing priorities, and I think the competing priorities are very important in this case, where especially big donor countries have reflected priorities on their own national needs. There we're back. So reprioritizing their own needs versus humanitarian aid to other countries. But also a lack of flexibility to adjust to a changing situation. And also in change, we have throughout the pandemic had many lessons learned, as we've talked about today. And it'll be back in a few seconds, there we go. Now I lost my thread. Our priorities, yes, so we learned lessons along the way of the pandemic, but we have, as a global community, I think, sometimes been a bit slow in adapting as we have gone along. I know internally we have also made mistakes in terms of priorities. I have examples of where we, in some cases, initially prioritized the COVID-19 preparedness activity over a malaria prevention activity. Saw a few months down the line that maybe the situation in this particular context was not going to be as alarming as we initially thought, and readjust our priorities. So I think the slowness of the system has had a big impact. So, I know I'm not the only one today who have a final slide that says in conclusion. What we have seen, so just wrapping up, the COVID-19 crisis and the economic downturn that we're experiencing right now has been contributing to a widening of the service gaps, how we are able to provide care and assistance. Funding shifting, resources being shifted, priorities changing. So what we're seeing is less coverage in healthcare provision, and we're seeing a slow system. As I already mentioned, the flexibility and the adapting to circumstances has been very slow moving. Impacts of COVID has addressed the aspect of doing good in many ways, but has it also been able to adhere to the principle of do no harm? By keeping the focus on COVID, on a high-level care, what we've seen is that primary health care in a lot of contexts has paid the price for this shift in focus. And diseases such as malaria, tuberculosis, and HIV, they have seen a resurgence partially because of this shift in focus. So funds' attention were shifted away. Healthcare staff were sometimes affected themselves also. either by being, getting sick themselves or being prohibited from working due to restrictions. And then looking at the principle of doing the best for the most. And once again, like I mentioned before, who says that what donors and governments decide that corresponds to the individual's autonomy and deciding what is good for them and what their main needs are. So I hope that this has now given slightly different perspective to the rest of the day, but still fitting into a little bit seeing a different way of how a pandemic such as this one has an impact. Thank you.
Thank you, Mia. Our first speaker of today was talking about the importance of keeping the tables together to cooperate and to create solidarity. And I think that the problems with HIV and tuberculosis and malaria that you were talking about really pinpoints the problems that we only talk about one question in a time. But how can we achieve that? How can we achieve solidarity? How can we make the world know what to do? And what can we do in Sweden? Do you to support strategies for improving health in developing countries?
Well, I think for the first, if anyone has the answer to that question, please let us know, because you'll be solving a lot of problems if you actually know how we can change. I think, let's say from a Swedish perspective, Sweden has always traditionally been a strong advocate for initiatives such as support to the Global Fund. So the Global Fund, for those who are not familiar, are providing large funding and supplying drugs and diagnostic tools for these diseases to low-income countries. Sorry. And we have traditionally been big supporters and also one of the big major donors for these types of initiatives. With the pandemic now and discussions around pandemic treaty, international preparedness for pandemics, etc., I think it's important that we don't also forget the impact that these kind of initiatives have on public health on a global level. So not forgetting the impact that such initiatives have just by shifting priorities too much on something that is maybe closer to home. Sorry, so I think it's important to keep the discussion up on the secondary consequences to public health on pandemics and not on the pandemic only itself.
Good. We have a new government here in Sweden now. So do you have like one sentence or two sentences to urge or say to the Minister of International Development Cooperation and Foreign Trade, Johan Forsell?
I mean, there are of course still details in the aid budget that are still to be announced, but I think it goes along the lines of my answer to the last question. That's like the tradition that Sweden has to be a big supporter for these kind of initiatives, the importance that it has for public health globally, and that we should be proud of that tradition. And despite what may happen with new directions and new budget, that we need to maintain that position. As being in the forefront on a global level for the support for these kind of diseases.
Good, thank you.
Thank you.